We are here talking about the use of integrated insulin algorithms for cardiovascular surgery patients. And I prepared a paper analysis. It was a retrospective analysis of program effectiveness around glucomander versus EndoTool in our patient population. Good glucose control is widely recognized as critical to the health impact for inpatient cardiovascular surgery patient populations. No question, right? Reduces perioperative morbidity and mortality. There remain a lot of questions around the absolute target glucose values we should strive for, and that's one area of interest for us. We have been using the EndoTool application for several years at our institution with a fairly tight target, 90 to 120. We made the decision to move to the glucomander application last summer. At that time, in clinical design, we raised the target to 100 to 140. And so our intent was to compare the mean CBG and the hypo and hyperglycemia rates in our IV population, and then to assess the downstream effects with transition to subcutaneous insulin. We changed initially out of concern for the CMS skip measure, which had changed around glucose targets during the IV insulin phase, and we were having difficulty controlling glucose during oral feeding. And we believed that the glucomander product would be superior, and so we made that transition then. Ironically, the skip measure was devolved, was retired. However, we still found that there were elements of the application for glucomander that we thought would fit our institution well. We have a very robust advanced practitioner centralized diabetes management program. So all of our cardiovascular patients are seen by a diabetes advanced practitioner once they come off IV insulin. This is supervised by hospitalists in collaboration with endocrinologists. We believed that the use of the subcutaneous application from glucomander, which is not currently available with EndoTool, would free up our advanced practitioners a bit to do other work. We also believed that their robust glucose surveillance, which monitors glucose throughout the entire hospital, not just the licensed beds, would provide opportunities for intervention in other patient populations. For the advanced practitioners, we found that we can rely on the glucomander application certainly for the first 24 hours after transition from IV to subcutaneous insulin. Previously, our APs managed every insulin adjustment after that. Now they manage about 50%. So a definite reduction in the sort of intensity of the AP service. The glucomander application is uniquely integrated with our Cerner EMR, which provides additional opportunities around streamlining some of the processes. And if we prove it to be true, that we can back end to the subcutaneous application sooner rather than later, that we will, between the streamlining of the process and a shorter duration of time on the IV glucomander, we actually reduce nursing intensity of care as well, which contributes to the overall reduction in cost of care. In a nutshell, reduced hypo and hyperglycemia with the glucomander application during the IV infusion phase, even with the higher glucose target. Every institution providing cardiovascular surgical care must make a methodical decision around the allocation of resources for glucose management. We believe that the fit with an advanced practitioner or some sort of expert oversight coupled with an insulin algorithm provide the best outcomes for our patients. And I would encourage others to consider the model. It frees up our endocrinologists to address complex endocrinopathies and other endocrinologic emergencies, while at the same time maintaining expertise in the field. I think for a long time the hospital setting was seen as a time to provide safe and effective glucose management, sort of full stop. We now know that for population health, we need to take the opportunity when people with diabetes are admitted to the hospital to help reshape their insulin or other management and provide them the education for long-term health benefit. Going forward, we will be looking very soon downstream longitudinally at the longer-term A1C and glucose outcomes for our patients. So that's the holy grail, right? The artificial pancreas. I would make the plug, however, that we have to think of people holistically, and that even once we have a closed loop setting with glucose monitoring and insulin delivery, we still need to engage people on healthy habits, best nutritional practices, so that they have the best long-term outcome, both from a standpoint of glucose control, but also weight management and other comorbidities. We have two next steps. We're going to do a more robust retrospective analysis looking at our time before and after the transition to glucomandir, especially looking at health outcomes. We already have very low rates of perioperative complications, but we want to look at those quite closely since we made some changes. And then we are discussing with glucomandir the opportunity to enroll in a multi-center trial, getting specifically to your point about after hospital care and the 90-day period post-operatively.